like to take a moment to land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder today, as always, to please leave your questions till the end of the presentation. Please enter them in the chat. And as well, we ask you to answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. And finally, today we do have this is a special occasion. It is the 100th anniversary of the Department of Medicine, and we would invite you to stay after this presentation on the Zoom link or in the room for those of you who are in person to watch this brief video on the 100 years of Department of Medicine at McGill. So finally, we have a great speaker today, as always, a great speaker, but I'm very thrilled that we have Dr. Alan Forster, who will be talking to you about innovation at McGill, and I would invite Dr. Mark Roger, our Chair of Medicine, to please present Dr. Forster.
Great, thanks very much, everybody. And just with respect to the Department of Medicine at 100, we're also going to be doing a quiz, and there will be a Department of Medicine Historian Award that will be announced at some point in December. So I encourage you to listen attentively and take notes during Ernesto, Dr. Schifrin's video that he's kindly provided or prepared for us. So listen, it's my great pleasure to introduce Alan Forster, who I've known since 1994, and actually before 1994. I graduated from medical school in 1994, and I knew him through there, and I was his chief medical resident. And despite that, he went on to great things. Alan did his internal medicine training in Ottawa and his master's of epidemiology in Ottawa, and trained at Brigham and Women's and Harvard in quality safety. He joined us here at the MUHC last year. Was the Executive Vice President and Chief of Innovation and Quality at the Ottawa Hospital, and is our current Director of Innovation Quality and Clinical Performance at the MUHC and Director of Innovation, and a professor in our department of innovation. So welcome, Alan, and thanks for enlightening us on innovation.
Thanks, Mark.
All
right. Well, thanks so much, and it's a pleasure to be here. It's my 1-year anniversary myself, so 100 years of McGill, but 1 year for Dr. Forster. And so it's kind of apropos I'm here to do this today. A year ago when I moved here, I was living on Mark's couch. I don't know, he's a great friend. He put me up in his place before I could have a place. So hopefully, I don't know if many recruits get that special treatment, but
They will now.
they will now, okay. And they get a house. So I'm going to spend a bit of time today talking about innovation, arguing that it's not just a buzzword and that it's actually really critical for us to really be thinking about how we make this happen, because we're at a point in time in Canadian healthcare, Quebec healthcare, where, and probably globally, where if we don't move things forward, we may in fact have some significant challenges, continuing to pride ourselves on having a great health service. And that being said, there is amazing opportunities to make it happen. And I will talk to you about those amazing opportunities as well as some of the challenges. And then more specifically, what we're going to do here to help move it forward. And my slides. Okay. So I just want to sort of give some context of the types of innovations I'm talking about. So, here are some, and some of them are actually developed here. Some are being used here. Some are struggling to get a foothold here. So here's a medical device, a dual balloon device to enable enteroscopic ultrasound-guided gastroenterostomy for management of gastric outlet obstruction. So the creation of a new medical device that now is becoming, helping patients have better outcomes. machine learning derived algorithms to allow wearable data to predict illness onset. So rather than wait till symptoms develop, actually be able to know from physiological data that someone's going to get ill and do something about it. A company called ASAP, it's an Israeli company, which has an FDA, the first FDA approved point of care diagnostic aid to really turn an iPhone into a bedside echo that can diagnose regional wall motion abnormalities, valvular abnormalities, ejection fraction problems, the point of care. AIMS, an artificial intelligence enabled platform to support patient monitoring using a machine vision coupled with artificial intelligence to prevent hospital acquired infections, whether they be complications like hospital acquired infections or falls or pressure ulcers or suicide or delirium, a number of hospital acquired infections. AI Doc, an AI-enabled radiology workflow platform that's currently being adopted in hundreds of hospitals worldwide to enable access to in order to enable more rapid diagnosis of stroke and subarachnoid hemorrhage. And has resulted in a reduction in mortality in hospitals incorporating that technology. AI scribes, and I think there's a bunch of people talking about that in the Department of Medicine, where you can turn a clinical encounter where you just have a regular conversation and assessment of a patient, and you walk out the room and you have a structured clinical note ready to be mailed to anybody. Hippocratic AI, this is another company, an AI-enabled clinical chatbot that replicates patient and nurse interactions for specific clinical scenarios. For example, for heart failure management or post-discharge checkups or pre-visit assessment reminders for endoscopy as examples. And Vitality, a big data application supporting evidence-based behavioral economic approach to optimizing individual and population health, and which has been demonstrated to save money and improve lives, and currently being used in different markets around the world. So these are, and I think you'll see AI is pretty common in these things that I've picked on. AI is the future. We're in the future now. It's here, and we've got to go. But what's the problem here at MUHC? What's the problem in healthcare, let's say more specifically? Because many of these tools are available in other industries today, but we haven't made them available. We haven't adopted it. And so today, what I'll talk about is innovation is the approach basically for addressing these challenges. And what I'll talk about is a little bit about the situation, why are we struggling and what do we have to be aware of going forward? What is the imperative for doing this? I'll talk about how we've developed the MUHC Innovation Way, which is, I would say is still being formulated, and we'll look to people in the Department of Medicine and others to help us move that forward. And then I'll talk a little bit about next steps. So just a bit of data on the situation. This shows different age groups on the bottom, and within those age groups, the Quebec situation in terms of the proportion at the population level and the percentage of hospital utilization within that age group. And you'll see, in the green, the distribution is there. But if you look at the far right of this, you'll see that people over the 80 years old today account for almost half of the bed days that we're using in our hospitals today. Okay, so that's, I think, something just to put in your mind as to something that and I don't think that's news to people that people who are older are disproportionately using the hospital. Comorbidity is another issue that is correlated with hospital utilization. And again, if we look at this is the same plot, but basically instead of age, it has a number of chronic conditions. And again, Quebec data. And if we look at just grouping them into one, none, 1, 2, or 3 or more, we see that people who have 3 or more, again, are using about half of the hospital days in Quebec. Okay, and again, that's really not newsworthy. We know that if you're on general medicine or if you're in the hospital, you know that your hospital ward is with people who are old and who have multiple comorbidities. And it's the same on the surgical wards. It's the same pretty much all throughout. then the last bit of data I'll show is just discharge dispositions, and this is length of stay by discharge disposition. And I think what's striking about this is just the marked variance that we see. And this talks about maybe more the system impacts. But we see, for example, if you go home, which is, more than about 2/3 of the patients, the length of stay is, well, probably around 5 days. Okay. If you look on the other hand, if you look at people being discharged to long-term care, that's about 5% of the people discharged from hospital. But look at the impact on length of stay. We're talking 25 to 27 days in hospital on average. Okay. And that is a massive impact. Okay, so I've talked about age, I've talked about comorbidities, and I've talked about disposition status. But if we look at what's happening in the population and demographic changes in Quebec over the next 10 years or so, we see doubling in people. We see a doubling in the population over 80, the total number of people. We see a doubling in the proportion of people with more than three or more comorbidities. And we see a doubling in the number of people requiring long-term care. And I can tell you that the plans are not to double the capacity of the healthcare system over that time period. And so if we think of the problems that we're having today, I think it's worth reflecting back and say, okay, where are we going to be in 10 years? And if we're going to set ourselves up for the future, what do we need to do? And I will say that this, I know I'm talking to a bunch of internists, but there is an effect on surgical access. And surgical and interventional access is a really critical part of what we do in healthcare, but there's a crowding out of what's happening and of our ability to do surgery by these factors that I'm talking about. And so, at the General, as an example, only about 20 beds today are dedicated for patients who need elective surgery. Okay, so, and that's because of emergencies, that's because of NSA patients, that's because of inability to look after. And so our ability to get cancer surgery or non-malignant gynecological surgery or orthopedic surgery is going to be diminished and diminished and diminished by this situation unless we come up with new ways of dealing with this. And this just shows a plot of historical waitlist numbers in Quebec, but also the projected. And so we've had a couple of years where we were able to recover from the pandemic, but really that's largely just a trend from what we were pre-pandemic to a bad situation. And if we look forward, it's going to get worse. And I suspect this is not even accounting for some of the changes that we're seeing with new technologies that are allowing us to do operations and procedures on people who previously we wouldn't have had the indications to do it. So there will be increasing demand for surgery. And this is also not accounting for some of those knock-on effects that I talked about in terms of the impact on hospital beds. A couple of other sort of burning platform issues. One is, the public is not happy with the situation. We're missing the mark on access to care, on quality. And that includes, how well we coordinate, how well we communicate, how well we include the patient in their decision-making. They're not happy about the safety, the error rate and the injury rate is unacceptable. And then the convenience. We're used to being able to do things ourselves, right? Like booking an appointment to go somewhere or travel or go on holiday or a restaurant, and we're able to find information about us and in a way that's almost seamless in almost every industry except for healthcare. Our healthcare workforce, and now just focus on nurses, we already have a high vacancy rate in our institution, limiting ability to do things. But the number of nurses is not going to increase proportionate to the demand. And in fact, we look over the next 10 years or so to be having probably about 3 times more exits from the workforce than we have today. And, just think about the other thing that's important about this is that the people leaving the workforce leave with knowledge of the work, right? If you're 50 or 55 or 60 and you're leaving a lot of knowledge of the system. And if you're coming in at age 25, yes, you've got the latest, but you also don't have that knowledge of the system. That's nurses. The same thing could be said for family doctors, physicians, others. Environmental sustainability. Currently, healthcare generates about 5% of all CO2 emissions. And we also have, an unknown impact of the global climate change on health. Like we're seeing certain infectious diseases We're seeing events occurring in our city, sometimes with crises due to flooding and other things. The social upheaval, civil unrest, famine, environmental challenges, and financial sustainability, which I think is really critical. Like people right now, we're going through budget issues in Quebec. Right now, we're spending about 40%, 43% of our public dollars on healthcare, and the growth rate would be 48%. Okay, so we're getting to a point where really we're not going, this is not sustainable really from a spending point of view, from a public first point of view and other priorities. So I would just say, I mean, that's a bit depressing what I've talked about, that those are facts. These are facts. These are not made up. And that is really what the imperative is for innovation. And the question I have is, and this is like, you know, I went through some of these things. How do these tools help that I talked about? Like, you know, a population-based approach to help minimize and prevent disease progression. Tools to help us get more rapid diagnoses. Tools to help us do minimally invasive procedures and prevent cases. Tools to help us with the manpower for monitoring patients and communicating patients. Tools to make physicians and other staff more productive. Why aren't we doing this today? Why aren't we doing this? Why isn't healthcare there already? And there's a lot of barriers. There's a lot of barriers, and I'm not going to go through all those barriers, but that's the imperative, is for us collectively. And this is why I was brought here, was to help put this forward. And so at the MUHC and the MUHC-RI and McGill, you know, how are we organized to lead the development and adoption of solutions to solve these healthcare challenges? And I would say, you know, McGill, like our institutions and our people who comprise those institutions are well positioned to help address these challenges if we take up that challenge. But we're going to need to work together, and I'll explain how we might do that. So I said at the beginning that I've been here for about a year. What have I done since coming here, and what have we collectively done? Well, we've worked to help define the innovation mandate. What is innovation? What's our focus? What's our scope? We've done an environmental scan to look at innovation programs globally. We've done formal and informal stakeholder analysis in which we sought input from literally hundreds of people, and that was from the different institutions. And we've developed a model to support innovation. And then the other part of my work, which is really around quality and clinical performance, is how are we connecting the dots between innovation and this overall health system performance, so that we're not just out there on sort of technology development, but we're understanding the broader system, and we're calling that the learning system. And I'll talk a little bit about that. So let's jump into the definition and focus. So our definition for innovation is as follows: developing new products, services, and methods that, when adopted, have an impact on the health of Canadians in the world. And in the below that, you see a flow from research to the creation of solutions that can then be tested and developed into products, which can then go off to be marketed and scaled throughout. And you'll see that there's a variety of stages below that are a little bit more detailed. And the idea here is to give people a pathway to understand what is the difference between, let's say, a research project and a quality improvement project, and how does that fit into this innovation pipeline. And this will help people understand, when they come forward with a product or an idea or a problem, how do they work with us how do we work and support them to help promote that? And sometimes that will lead to a commercial product, but sometimes it'll lead to a quality improvement process in the hospital. And sometimes it won't do either of those things. It'll just stop. But in all cases, it's using data and evidence to guide decision-making. So based on this definition, innovation can include new products and services that have a potential to be commercialized. And I will say there's a heavy predominance on digital innovations because of the nature of digital innovations and how far behind we are, and how they can be quickly leveraged to make big differences. It also includes social innovations that don't have an opportunity for commercialization, but which we can support and promote because of value creation for the health service or for patients. And then And then, but it doesn't include the early stage research that we're doing in our labs. It doesn't include quality improvement. The idea between those is that the scaling opportunity and the ability to create value from something new are not present or are undefined. So I mentioned, so that's our definition and focus. In terms of strengths and opportunities, I'll just say, many things I'll just say about McGill that I think are quite, and MUHC are quite well known to you guys, but, it coming from outside, it's sometimes nice to see, like, the global reputation and brand of McGill is incredible. And I don't think that should be forgotten about ever. It is a huge, huge benefit to innovation and a huge, huge benefit to any academic work we would do. The global reputation is based on the amazing people and ideas that are here and throughout the institution. The significant research success that comes about through it, and I guess academic success more broadly. There's also in the culture here a tremendous interest and excitement for trying to make change happen. And that is well themed. I would say there are people who feel a little bit demoralized because of change fatigue, I would say, and perhaps they're just how to move it forward. But there is tremendous interest and excitement. There's a number of government programs which I'll talk about. There's some strong interest from the investment community to help support people with commercialization activities. And then we also have something here called the CLIP, the Clinical Innovation Platform, which is an incubator, which allows us to bring in companies and has had some very successful relationships and ideas come through. And those are all strengths that we should be proud of here. In terms of the opportunities, I don't think many of these will surprise people. We do see, the ISIT infrastructure, while ahead in Quebec, is probably not where it needs to be from a national or international perspective. There's a need to move forward and may limit us moving forward, but also could be a place where we do a leapfrog if we do it right. Silos of activity, and this exists in all organizations and in healthcare, but it's also here. And what I mean by that is that there tends to be like a lack of awareness sometimes of the opportunities for collaboration. And one example is MUHC, MUHC-RI, and McGill. And we really need all three of those to play together. People don't see an end-to-end process for how to move an innovation forward. And that really gets in the way because people don't, if you're speaking to a decision maker, are you doing a proof of concept? Are you trying to understand the problem? Or are you actually testing something in a clinical environment? Or are you moving now to a commercialization phase of this? And that really makes it difficult to make sure what your ask is correct, and what you need to do to be successful is success. There's some challenges with flexibility of thinking and contracting. Our tech transfer policy and approach needs to be solidified if we're going to move this forward. A speed to decision making is something that I think many big organizations struggle with, but partly because of the siloed nature and partly because of the a lack of a knowledge of what we need to do. We're just stuck in various steps of this stuff. And I would probably say, as a result of those opportunities, those opportunities for improvement, I see a lack of trust at times in the organization. Where people don't trust administration or people don't trust different business functions in the institution, and that gets in the way of success because people don't. If you think the worst of something, then it's hard to collaborate, and we need to get over that if we're going to be successful. I will show you that this is a complicated environment, and to a certain extent, this means that there's great opportunities, but it also makes it hard for people because do you go talk to MedTech and get funding from them? Do you go talk to the Bureau d'Innovation and the Ministry of Health? Do you get money from CIHR? There's funding through venture capital. There's many industry partners. There's networks, foundations, all of which are playing in the innovation sandbox. and all of which create an environment for clinicians and scientists to play in the innovation sandbox. But there, as I spoke about, the lack of a clarity of an end-to-end process and governance over this makes it very easy for people to go down blind alleyways. So they'll get a grant, they'll get funding, but then they go forward with a project and no one from administration knows anything about it, so they get stalled out. They may even get through that hurdle and they'll have a tech transfer agreement. The investors may not find that attractive and may walk away. There's not really good support for people as they transition from an idea to a startup to something better. And as a result of this, and there's a lot of people here in this space who know the answer. I'll just say that, like in their where they are, they know the answer. And there's very few people who have a view on the overall flow and how these things can help each other to be successful. So it's quite normal that these silos exist, and it's quite normal that people are struggling. So I mentioned that's our kind of internal look and our look at the local environment. If we look at the environment, like more broadly, like we look at other innovation success stories at an industry level, or if we look at within healthcare, I think there's some things that can be said as truth. One is innovation cannot be optimized unless it is managed. If you're going in too many directions, you're never going to succeed. If you're not betting on the horses that are going to win, you're not going to succeed. If you're not creating capacity and culture and process within your organization, you're not going to succeed. If you're not building the infrastructure, you're not going to succeed. Like so you have to, and if you're not investing the right amount and getting the mix between your operations and your innovation and transformation efforts, you're not going to succeed. And so it has to be managed, and that's a very well-established approach. And there are ways to apply those. Okay, so that's the number one. Number two, globally, innovation programs within academic health science centers, and there's a number of very successful ones, specifically in the digital health space where we're going to be playing, that have like consistently delivered the following benefits. One is they become a catalyst for broader transformation. Yes, you might be testing a point of care diagnostic assist device, like to help you do an echo, like to help a nurse do an echo and rule out tamponade at the bedside. That's a technology development, a very specific thing. But the more of this you do, you create this broader catalyst for transformation, and it can stimulate change. So, you know, what are those sort of things that you bring in that will create broad systemic change? Like when I presented the sort of initial data, it's like it is somewhat overwhelming. Where is that thin edge of the wedge that if we move in, we can start to see transformative change start to happen? It can be an engine for economic wealth. Okay, so you know, on the one hand, you know, healthcare has been on the cost side of the ledger for most of healthcare's existence, but it can also become a revenue source at times. And people see that in cities, and people see that in institutions. And this is again a consistent finding. An enhancement to this can enhance engagement of clinicians and staff. So if in the institutions where they have paid attention to this broad innovation program success, it becomes a draw for people to get engaged in driving improvements in healthcare quality, not just for innovation, but for healthcare quality more broadly. And then lastly, which I think shouldn't be forgotten, is it can be a way to get ready for when those emergencies happen, right? Like a pandemic or some social upheaval or some kind of crisis, because you're used to solving problems for the business, and you build a capacity within your workforce and a flexibility and nimbleness. And so these are all, I would say, consistent findings and the benefits of a managed program. There are global models. Here's 6 of them. And I'll highlight 3. UHN, you know, in Toronto, they're pulling in right now about $20 million a year in licensed revenue alone. That's not including their IP. all of that money is flowing back into further enhancing quality of care and further innovation activities. So investing in those next projects and investing in those next ideas that people have, 100% of that money is going for that purpose. And the way they've done that is they've built through their foundations a way to de-risk, but also a process map for moving these through in decision-making. I mentioned University College London and Imperial College. Those two are working very closely with the NHS, but their IT departments are developing solutions which then get taken out to scale throughout the whole NHS. And again, there is a private sector opportunity there, but they have a methodology for both solving process improvements that are not commercial versus those that are. And so you might find a way to improve the business using existing products, existing technologies you own, but it isn't a commercial, it's just a process. It's just a process improvement. But then they also have a mechanism where they have investors and guide people to help support that translation into product development. Sick Kids has a very similar approach to UHN. And then I've highlighted MGB and Sheba, both of which are, MGB is again probably the one very impressive place, but because of its history, I mean, we're not there. It's been around us for much longer, but that's just license revenue that they're pulling in annually to support improvement work. And the Sheba, they've been working at this. They opened their ARC in 2019, and since then they have over 100 startups and other companies currently valued at 3.6 billion, for which they own significant proportion of that. And they're just now beginning to start to see exits that are coming back to generate benefits to them. I didn't describe their license revenue there. So just to say that there are ways to structure and manage, and sometimes people get a bit concerned that we're mentioning the financial aspect of this. And I just want to comment on this. If you make a solution for something that doesn't become a product, then the whole world no one will ever get it. Okay. And if it becomes a product, it can only be useful to people if you build a business plan to help that product get to the market for people to use it. And so, and assuming it's beneficial when people use it and choose to buy it, the revenue that's created from those products is a marker for the impact you're having on the world, right? And so I think while it's maybe something that we in healthcare don't always like to think about, but there is a financial aspect of this and it is a way of putting a marker on the impact you're having. As well, in times like they described, we need to think about how we reinvest to reinvent the business. Otherwise, I can guarantee healthcare does not provide the capital to do that, to build the tools and invest. So what are the enablers? If I've mentioned some of the things, enablers, innovation, in these success stories, it's consistent. Innovation is the priority of the health system. It's not the university or the research institute. It is the health system is saying, of course, the research institute and the university are important and care about innovation, but it has to be embedded within the health system as a key priority. And must be viewed as a vehicle for broader transformation efforts, not a standalone moneymaker. It's actually to re-transform the business. You're going to make the business better as a result of this innovation. By definition, it addresses patient need. It's about making the needs of the patient be met. And that's the purpose of innovation. It's not any other purpose. Collaboration and trust are critical components and need to be thought about on a regular basis and almost embedded as key values within the effort. Access to capital and business advice are key components for moving forward, and oftentimes these have to come from outside of healthcare because we don't have those skill sets in the institution. Process improvements and application of things like Lean and Six Sigma throughout the life cycle of innovation, going from that need to a product, but also in every single initiative you're doing have to be built in, and very well accelerated projects to demonstrate success are really critical, because there's time to value here that we need to move forward with, and we have to have real clarity as to we're doing a good job with their evaluations. Education and capacity building are required. I would say we have a lot of those already. And then benefits must be based on a shared value model. So if we're collaborating with private sector, there needs to be a mechanism by which the public entity benefits. And again, that's a culture change that may people struggle with. But I think it's probably on both sides, on the business side and on the public sector side. How do we create that shared value? And there are some really great examples of that. So with that in mind, we've come up with our program goals and ambition, and this is in words. The program will facilitate and support the end-to-end innovation process at the MUHC and the Research Institute, guiding clinicians, researchers, entrepreneurs, and the ecosystem through the scaling and commercialization of their innovations for measurable impact on health by building clear and cohesive pathways. And we have the following goals. Number one, demonstrate direct benefits for patients and staff of the MUHC-RI, the health network and populations in Quebec and Canada and the world through our portfolio of innovation. So we'll be able to say, here's what we're working on. Here's the benefits we're seeing. Goal two, generate revenue to reinvest in further advancing innovation and enhancing our system. So how would our world look differently if we had $20 million a year to reinvest into digital innovations locally? But why stop at that? Let's go for the MGB or the Shiba. Goal three, become recognized globally as an innovative leader in the focus areas defined for the innovation program, attracting innovators from around the world to pursue their innovations with us. Now, I will say we already are doing some of these things, and so it's like we're launching by making the program. And then four, empower our people to easily access and engage in the end-to-end innovation process, fostering a culture of innovation. So those are the goals. We've established a plan now, and I won't go through this in detail, but just to say that there are things like objectively that we can move the bar on. So the first is to be the voice of innovation. We need an anchor, and that creates the culture and creates the strategy. We need to be a leader and connector in the community. We need that crazy map of all those people. We need to kind of figure out how we play in that sandbox. And we also have to create a place internally at the MUHC. If you're a company and you want to work with us, it has to be good for you. We have to make value for that company. They're going to pay for it. We have to be able to make that. They're betting their future on us. If we don't make it strong opportunity for them, we won't succeed. And then finally, accelerating innovation through an effective operating model and mechanism. So that's the internal work we're doing. That includes accessing data, accessing our facilities, creating access to like funding, whether that be private money, capital money, or whether that's research money, or whether that's foundation money. And then to facilitate that commercialization process, which I've talked about. How do we make sure we protect our knowledge so that it can be commercialized? And we do so in a way that's attractive to the investment community. For this to be executed, we've developed a governance model where we see a joint oversight by the RI and the MUHC. We're developing what's called a Joint Innovation Council, which is about to launch. There's going to be a core functional team. The core functional team will be really around project management. Will also be around how we support data and access to change management expertise. We're calling that the Health System Intelligence Platform, aka the Adam Center for folks who are aware of the MD clone work we're doing. And then our CLIP, that's our incubator. And the idea is that that's the core team, and that creates the abilities for folks to move through. And then we have scientific collaborators, and there's many, many of those, both in terms of ideas to come forward with, but also methodologies and platforms for support. And those can come in as a case-by-case basis, but we may build up specific expertise in specific areas. Below that, that's supported by an innovation partnership office, which is really helping with some of those administrative functions, contracting, legal advice, IP, etc. And then we have the culture, which is so important, which is going to happen through a sort of programmatic education approach. And some of that will be more like, but I'll just say micro-credentialing programs, like a data analytics program. But we might also, we're linking with the graduate programs at the McGill. And there are many of these things that exist already. So I'll just say that we're not building from scratch here. It's about putting it together to a story. And now we get into like, how does it help people? So what we've defined and which are further being elaborated are how does it work for people? And we see that there's an in like a channel in and a channel out, okay? And the channel in, we have internal folks, we have external folks, and we have strategic partners, and then we have some like think tanks where people are coming to us, governments and things, saying what here are some opportunities. So those intakes, we have to have a very clear process for people to put their idea forward and to help them move that forward. And really the Joint Innovation Council will be the group that supports that. And we will be using objective measures to help move that forward. For the externals, we see that there's a pay-as-you-go kind of model or a partnership kind of model. So for the pay-as-you-go, like if someone wants to do a clinical study or a clinical evaluation, or they want access to subject matter experts, there's a membership fee, there's administrative costs, there's actually fee for service for the activities. For the partnership, there's more of about like, how do we create longer term benefits to both parties? For the pay-as-you-go, it's really about doing a study. And for the strategic partner, it's like, how do we build products together that are going to come back to help us both? And there's a bit more overhead, obviously, for the partnership, but we see some benefits. So, for example, if something goes to a commercial product, you create a licensing agreement where we get revenue, a trailing revenue from the product being used. We get a rebate, perhaps, to use it here. And similarly, we can own some of the equity in the company. Those are parameters which can be varied depending on the type of relationship and the type of thing we're building up. For all of these, there's clarity of when there's a go, no go. And I think part of the challenge is making sure that people understand what the criteria is for the go, no go, and helping them get to the go. I mean, that's really what we need to change the health system. We need to change, but we need to be, I think more than anything else, we need to be clear on what gets you to a go decision. And we have metrics for that, which are now coming forward. Number of projects, the amount of impact. And these are aligned with those goals I talked about previously. We have the net revenue generated, declarations of inventions, formal partnerships with industry players. And then we have our culture change. We have innovation building blocks that we're building out. We have our innovation projects within each mission or within each group. And then we also have people's perceptions, both in the hospital and outside of the institution, as to whether things are making a difference. So that's kind of the innovation program, the MUHC innovation. We've got a goals, aspirations. We have some metrics of success. We have a strategy, and we have a governance framework with an operation team to help make it happen. And right now we're in the process of making this happen for people. And there's a number of great successes as they're moving through those pathways. And people have been moving through those pathways without knowing that those pathways existed. So it's about, like, for example, we've got Michael here from Glen Ventures. He's out there trying to create a fund, and he's working with Investissement Quebec and others to try and make that a real thing. And Nadia and others and Renzo have been building Venture Studio, and there are people out there building these building blocks to make it happen. And sometimes they get frustrated. It's because their pathway we haven't moved it forward together. And it really is about that group of people working together to help move this forward. There's clearly amazing things happening, and I've just mentioned a couple of them there. But I will say that there is an ongoing tension, and I think it's something that we need to kind of address and make sure we cover it forward, which is, we have this traditional mission of research, which we have to pay attention to. We have this new thing, innovation, the buzzword. We also have quality improvement. We have to make sure that the system is functioning well, the health system is functioning. And I will just say that it is incredibly confusing to people to introduce terminology into some things that we've always done a certain way. It can be confusing. Like, is it research? Is it innovation? Is it quality improvement? Like, what am I doing? If you have different pathways for these things, it can become very confusing. If you have different rules of engagement and rules for how it works, it becomes very confusing. So we have to consolidate those and reconcile that. And the way we're doing that is, like, I am the VP, the director for all of it, but the idea is that we're working in the portfolio to make it all happen, right? We're trying to make sure, like in my role as personne mandatée for the research enterprise, I'm making sure that the functions work well. For my role in quality and transformation, it's really about how do we make sure we have the data and we're aligning against corporate mandates. And for innovation, how do we align it to these things? And again, that can be confusing. And what we're trying to do is, they're not really that different. The purpose is to make healthcare better for all of it. And when I say better, it's better for patients, better for staff, better for payers. Sometimes you do fundamental research to understand how to do this. Sometimes you do quality improvement to improve a process. And sometimes you do innovation to develop new technologies and get them into use. And that's not that complicated, but to make it happen is where the complications start to happen. And there are frameworks to support that. One's called the Learning Health System Framework. It's pictured on the right. I'm sure people here have seen that before. But the idea here is that there's a data platform that helps transform our clinical care into data, and our data into evidence. And then that informs practice change. And around all of that, you have research to support and inform the evidence. And so we're always collecting data. We're always creating evidence. And we're always looking for those best ideas to implement. And when we do that, we take it to market. So that's the learning health system. So we're building, like, that consists of a data platform. It's agreed upon goals and metrics. There's ethics and patient safety by design. And we create distinct on and off ramps for that process as well. So we've been doing that. We've implemented, or we're in the process of implementing MD Clone. And that launch is going to be early January. So that will be a platform for people to access data. We have a performance framework now formally adopted by the MUHC with a scorecard and agreement by the board with metrics, and that goes all the way down to missions. We're putting forward, and we have training now being built out in quality. So a funding model, patient safety, patient experience, and in operations management. We're building out training in quality improvement. So how do you analyze variation? What systems and leadership? And then we're building out the innovation program, as I discussed. So there are some big things, and I'll talk about that in a second. And then lastly, the personne mandatée function, I know, which is very frustrating for certain people who are involved in research, but accelerating approvals for research ethics, accelerating contracts, accelerating the patient, the privacy impact assessment. So a lot of big things going on. And then lastly, like, I'll just talk like the next steps with our innovation program. And this is just to finish. I've got 2 quick slides left to show. One is our strategy, furthering out the strategy. We have to go through an exercise now of what are our areas of focus. Where are we going to make are we going to make it through precision healthcare? What does that actually mean? How do we turn that precision healthcare into benefits? Is it virtual care? Is it big data? Is it robots? Is it medical devices? Where do we get the biggest bang for our buck here? And where do we want to spend our money? And where do we have those synergies in our organization that we can make a big difference? So that's next. The second is we're in the process of pushing through this governance and process optimization. And the more we put it out there, the more we'll get that better. So we're looking for your help on both of those things. The developing our open innovation capabilities. So I've talked a little bit about partnerships with private industry. We need to make that very clear how it works, and we need to be brave, and we need to push it forward, but we need to make sure that it actually supports us. And I did talk about the shared value models, and that's something that we need to be very explicit about, because otherwise people in healthcare get kind of antsy about it. Publicly funded healthcare get antsy. Innovation, culture change, staff benefiting. So we need to get those champions and support them and make sure that they're visible and make sure they're doing well, good stuff, and then help them take those ideas to others. And then we have to have broader based education. And then finally, the commercial management, enhanced declarations and access to capital. And you know, at the end of the day, we're not going to do anything without money. And so we need access to that capital to help us get the seed going and get the trees growing in our gardens. And then I want to just wrap this up with bringing it back to those big problems we had at the healthcare system. And you know, one of the things, and this is a map that I put together when I first got here, as a way to test out what we need to do in our transformation. And you know, it's very easy to worry about the data and worry about the companies and about like technologies and not think about the big picture. So I come back to the big picture and I'm trying to say, okay, how do we know whether we're moving the bar forward in our big picture problems? Okay, so the way we do that here is through our hospital balance score. Like we have a strategy for our hospital that's aligned with Santé Québec and the ministry, and it's like where we need to go as a hospital, okay? As a big teaching hospital, as a head, like the McGill RUIS, this is what we are, okay? And this is what we have to do for the population. And below that, we have a financing program that if we're not on it's called the FAP, if we're not on side with, we're going to go bankrupt, okay? So we have, here's where we're going as an institution, and here's the thing we have to really pay attention to from a financing point of view. But again, those don't speak to people. So can we go a lower level, a layer lower? So enhancing access to people for surgery or procedures, whether they be interventional procedures, like an endoscopy, for example, minimally invasive surgery, minimally invasive devices. How can we get people access to these and get them better and better and better? How can we improve quality of life for vulnerable people? Right now, probably 100 beds out of our 1,000 at the MUHC, the RVH and MGH are filled with NSA patients. How can we make sure those patients don't show up at our doors? How do we make sure that they get out faster, right? To that point of the graph, the people waiting long-term care, can we do better on them? Can we accelerate access to emergency? We show up in the hospital in emergency with sepsis, or with a stroke, or myocardial infarction, or acute abdomen trauma. How do you get into the system quickly and make sure your procedures get well done and then get out? How do we improve the care of patients with chronic illnesses so that we can bend that cost curve and that time to care and improve their quality of life, make it so that they're more patient-centered in their delivery of that care? And then can we support prevention of and then the recovery from disease? So if hopefully you prevent the heart attack, but if you don't, how do we get them back to functioning well immediately after? And below that, it's the culture. It's using data to inform decisions. It's demonstrating benefit from that alignment of research and clinical care, which is the innovation model, and then develop the collaborative efforts for the learning health system, which really is around those partnerships across and inside the organization. So that I drew that when I first got here, and I keep coming back to it to say, am I still doing what I think I should do? I'd love to hear if people have any criticism of this, because I want to refine it, but also any other part of the talk, I'd love to hear questions or comments. Thanks.
Thank you, Dr. Alan Forster, for this fantastic presentation. You made very clear, very complex topics, so thanks for bringing clarity to that. And we're very fortunate that the leadership at the MUHC had the vision to prioritize innovation. We have a few minutes. Are there any questions in the audience? Yeah, Kaberi. Dr. Dasgupta, yes.
First of all, I love your energy. This looks very, very exciting, and we need some good news these days. So that part is amazing. Now I'll say I'm a progressive leftist at heart. So it's great to work with companies. And the challenge that I sort of feel is that if we're partnering with different corporations to have innovations, but at the same time, the primary purchaser is the government, and we want, the most sort of cost-effective, fair solutions. Then, to me, the perfect landscape is where the innovators and vendors are in a constant state of competition. And so we may partner with someone and they may have a great innovation, but they might be displaced the next day by somebody else, and we should be open to that. So how do we ensure that it doesn't become, you know, a situation where, well, we work with them, we have a loyalty, et cetera, versus real competition?
You know, I think that's through first of all, diversity of the portfolio, like what are we working on? It's also through using data and intelligence, like not, and being careful and prudent with our, sound business judgment with making commitments to people. So, but I would argue we're doing a lot of those things already, right? Like when we go to buy a hip for hip prosthesis, we have vendors. We work with them, and they all come to us to say mine's better and mine's cheaper, but actually it's more expensive and unclear how much better, right? So I think those are issues we're dealing with today, and we have mechanisms. This just moves chain up a little bit earlier, which I think gives us even a little bit more control and power, actually.
Matthias?
Yeah, so Matthias Friedrich, and I've listened to your presentation. I just came physically here, but I listened to it, and it almost made me emotional because I've been through that since over the last 20 years. And I have basically had a lot of negative feedback for being involved in industry, having found startup companies. But on the other hand, I could help, for example, the University of Calgary to gather $8 million from these activities with a company I co-founded. So the cultural change, I think, is a huge effort. I'm also politically a leftist, or if I may say so, but I have really understood 20 years ago that our research is going nowhere if we are not personally involved in how this eventually is brought to the people, because only then can you ensure the quality, the purpose, and all that, and eventually also apply it in your own environment. And I'm still a clinician, I'm still a scientist, but do you think it is, because I experienced that compared to other universities, at McGill, we are lagging a little bit behind with this cultural change. Are you optimistic that this will change?
I wouldn't have come here if I wasn't. I think there is a big culture change, but I don't think it's quite as big. I think it'll flip. Like McGill, despite what you say as being a challenge, McGill actually has more is the best university for startups. It has the most unicorns outside of the US. Like, in Canada, it has more unicorns than anyone else. Like globally, it's seen as a very good place to come. And so if we have people creating technologies, creating approaches, they'll come here for school, they'll come here for their postdocs. I think it's more on the health system where we have the culture change. But again, maybe that'll flip quickly, because I showed some of those forces that are coming. Like, I don't think we're going to be in a scenario where we can be, like, government-run health services have to change very quickly because the demographics and the social forces are so strong, and the current approach isn't working at all.
We're running low on time, so I'm going to ask to be quick. I'll just take a question from the chat. How do you see MD clone being useful? And then
So I think MD clone will be useful because it'll give people a tool to see what's going on in their environment. That's one. Number two, they'll be able to model out the potential benefits of a variety of technologies in terms of our cost and outcomes. And three, it's a platform for sharing data with industry partners, which will speed up their collaboration.
fantastic. We have another question here. Yeah.
Hi, I'm James Twee. I'm a radiation oncologist. I found your speech very inspiring regarding the innovation. I do believe that innovation is one of the key to provide solution to all of our obstacles. However, a lot of the innovation that you have spoken about relies on AI, and AI relies on IT infrastructure. I find even when you bring the money to the hospital, there's a big bottleneck in terms of moving things forward, especially in the context of Santé Québec announcing all of these cuts. Like, do you foresee this being worse, or is there a solution in the pipeline to accelerate and help innovators to work with IT?
That's the purpose of this, is to accelerate it, because if we don't, it'll just be worse. It'll continue to be bad. If we have to, and I want to say, like, this is us working together. It's not, yes, it's me, but there's a whole bunch of us in this. And if we don't create a method for that investment to come brought in, like, again, like UHN model, 20 million a year, just from licenses, not from IP, just from licenses, coming back into them reliably so that they can invest a portion of that into data science, data platforms, the next projects. And we have to make that happen. Otherwise, as you say, the government will never pay for that.
Fantastic. It's coming up on 1 o'clock, so I will have to stop the presentation, but there are some questions in the chat. Maybe I'll invite Alan if you want to answer those remaining questions. Thanks everyone for joining us. I invite you to please stay on. Dr. Roger, you have a few words to say. Dr. Forster, congratulations for all the work you've done. We look forward to seeing you back here next year.